So we're going to talk today about the intersection of IT, innovation, clinical care, etc., and hopefully give you some ideas that you can take home. So let me start with this, right? This is sort of scary to a lot of people. Call it the FANG. Facebook, Apple, Amazon, Netflix, Google. You could throw Uber. You can come up with lots of variations. But these are the guys who are scaring everybody, right? Because this is what happens. When Amazon looks like that, someone else looks like going on the downside. In this case, it was Sears. I actually am surprised. There are actually still a couple of them around, but it's not good for them. There are a lot of places that have been disrupted. Now, it didn't happen overnight. Healthcare has definitely been the one place that has not been disrupted as much yet, but it's inevitable. You all here are in leadership positions and have the potential to do it to yourself before it happens to you. Because this is hard, by the way, to find the Thanos snap online. I had to do a couple things, but here we go. If any of you saw The Avengers, Thanos snap, the sort of godlike creature who with one snap changed the world. So the issue is, what if that happens to you? What if, right next to your clinic, Amazon decides to take over the next office building? There's an Amazon Go in my building in Chicago. Have you ever seen Amazon Go? Has anyone actually gone into one? Like one person? It's pretty cool, isn't it? You check in, you get whatever you want, and then you walk out, and it knows everything. Turns out there are cameras up, everything's following you. The idea is to be no cashier, no helpers, although right now they have people helping you out because everyone's so confused about it. This is on top of online, so they're going actually now into physical spaces, as well as, of course, doing everything online. But bottom line is, Amazon, Google, etc. They've tried there, and they continue to try it again in the healthcare. They've not succeeded quite yet, but they're getting closer. Amazon's recent purchase of PillPack allows them to be a medical distributor on top of other supplies, etc. Apple is doing a variety of things in healthcare. Google knows probably your medical condition before you do. Based on your searches, there's evidence that they can detect whether you have pancreatic cancer before you even know you have it, based on the type of things you might be searching for. I'm itchy, I'm turning yellow. Maybe even as simple as that, based on your age, etc. We are in what some people will call the surveillance economy. Everything you think is free is not really free. You've given up a lot of data to get those free devices, apps, etc. We'll talk a little more about that later, and definitely later this afternoon if you come to the workshop we're doing on evaluating these tools. So today, I want to give a little more background on where I'm coming from and the healthcare system, where it's headed. I want to talk about innovation. I've studied and been involved in innovation for most of my career. I want to share some thoughts with you on that, and then specifically how to innovate in healthcare IT. All of you probably have amazing IT systems, electronic medical records, and others that you just love because they work perfectly and they solve all of your problems. And I apologize if I bore you with some ideas on that. But in case they aren't perfect, I have some ideas for you. I wrote a book a couple of years ago where I brought in a number of folks in my community in the IT innovation space who helped us put together a variety of stories of how we could innovate in healthcare IT. I'm going to share the summaries of those with you. And then how do you transform and disrupt? And we're going to give you a couple thoughts on in mental health, what's happening, and what you might be able to think about. And I'm going to try and be as specific as possible so that you can actually take something home. I'm going to be a little up here, but I also want to be very realistic. I really hope that at the end of the day you can take home some specific ideas and realize that, yes, this is big and scary, and oh my God, can you do it? Yes, you can do it. There are stories after story of folks like you who are able to disrupt in their own organization in a variety of ways. And hopefully if I give you just one little story or nugget that helps you do one little thing, that's a great start. So my background, I was an engineer, but knew I wanted to be a doctor. I worked at Northwestern Medicine most of my career. I can now say it's a top 10 academic medical center, according to U.S. News and World Report. When I started out, it was a small, I helped start out the initial primary care group owned by the hospital. We built it eventually to about 200 plus providers, the largest primary care group in the city of Chicago. We were big fans of the co-location model. We worked with a behavioral health group who brought therapists into our offices. We gave them space. It was a wonderful experience. I've worked in a couple of startups over the years in the EMR and consulting space. I met this guy over a decade ago. His name's Peter Solozzi. He was a sort of an early innovator in a completely different space, not in healthcare, but he became a patient and a friend and inspired me. And when he passed, his friends and family provided some funding for me to start the Solozzi Healthcare Innovation Program at Northwestern, one of the earliest healthcare innovation programs. And I was able to learn a lot from a network of similar innovators called the Innovation Learning Network. It's a nonprofit consortium of organizations in healthcare who focus on innovation. Wrote this book with the founder of the ILN, Chris McCarthy, and we brought a lot of ILN members in to write their stories. I've had some startup experience, started a company called HealthFinks. I'm on the board of a company called OneView. Started some other practices, and currently, past year and a half over that, worked at MD Live, as the chief medical officer for the core company and the president of the actual medical group, where we do serve. We provide urgent care online. We're expanding into primary care, and we also have behavioral health therapists and psychiatrists online. So a lot of telehealth. So there's a bit of that flavor in here as well. So today, I really do want you to take home some ideas that you can use to disrupt yourself in a fast but safe way. I promise I'm not going to let you go off the cliff, but there may be a couple of things that you can do in a safe way. So I do think the future of healthcare is virtual. Boy, it's hard to see the different blues here. But this is a study by University of Rochester that suggested that the office visit will actually be going down over the next 10 years. And the virtual visits will be going up. And if you think about every other industry, it's gone a lot faster than this. When was the last time you went to a travel agent, got something out of a video store, went to the bank to deposit something? We still do those now and then, particularly if it's complex, but we do more and more of it online. We do more of it on our app. We do more and more of it as self-service even. Although in healthcare, the providers are still needed in a variety of ways. So one of the ways I look at healthcare is through the pyramid that looks at the population of very sick people, small percent who represent a lot of the cost. In fact, my hunch is you all take care of a lot of those folks. The less sick people might be taken care of by primary care and or don't even go in because they're not that sick. And I believe the future will be more and more of the routine stuff being online and the complex stuff being in the office. And in fact, the ideal future may be that really sick people are able to get in the office and spend much more time with their providers in a much easier fashion. I often talk about that the future of internal medicine, and perhaps in mental health as well, is that the providers in the office become the complexologists, take care of the sickest, while the online care, whether it's self-service or virtual visits, et cetera, and digital apps, are for folks who have routine, repeatable things that don't need as much time and attention. This is one of the ways I talk about what the future might look like. What if we made primary care online? What might that look like? It's a little hard to see here. I'll walk us through it. But the idea is you go online. How many people here have a primary care? I hope I'm not going to violate HIPAA, but how many have a primary care doctor? Excellent. That's better than it. How many of you have seen them for an annual exam in the past year? Okay, you guys are ahead of the curve because that's great. How many of you have done any type of online visit with your primary care doctor? A couple. And by the way, it's so funny because we talk about like it's new. We've been doing it. The first telephone call was an online health visit. Mr. Bell had spilled some acid on himself and called for his assistant. Please come here, help me. Went through a telephone, right? We've been doing it for a long time. And in behavioral health, by the way, particularly doing and getting charged for it. Has been very common to do phone type visits. My whole career, I was doing email in the 90s with patients, well before HIPAA was around, thank goodness. But it was really easy. I just had to know that Red Runner 6 was Mark Smith or something. It was hard, had to be clear, but not that many people were emailing. So what if you go online, and this is what we're finding is when we talk to large health plans who work with us, a lot of their patients don't have a great relationship with primary care docs. Nationally, the estimate is around 30-40% of people don't have a primary care doctor. And even if you do, the rest of folks don't have a great relationship and go in regularly. Recent claims analysis showed that maybe 25-35% of people actually have seen their primary care doctor for an annual wellness in the past year and a half. It's interesting. When they surveyed them, 80% thought they had, but based on claims data, only 30% had. Bottom line is, variety of reasons. They don't have a doctor. They don't have time. People are not going in routinely, or maybe they don't know about it. So what if it was online? What if you could click a button just like you could with Netflix and start the process, answer a couple of questions, get sent to a lab in the future. The lab will get sent to you. It'll just be a little box. We can send you a blood pressure cuff, and then a week or two later you see the doctor. But by that time everything's been processed, so now the doctor can just focus on what, if any, findings were done, talked about your issues, make sure you're up to date on all of your wellness exams. And then maybe they'll give you a digital app to use. And then throughout the rest of the year, that digital app is going to be following you and checking in on you. The doctor might do another checkup with you, a quick 5-minute, how are you feeling? You might continue to go. The digital app might find a problem, alert another one of the doctor partners who can then refer you in to see a specialist, get another test done. You might have some anxiety, and they can refer you to an online behavioral health therapist who can do a couple of visits with you, get you feeling better. You'll continue throughout the year, maybe do an urgent care visit for the flu, and then start the process over again. But the truth is, primary care, behavioral health, dermatology, and many other routine care can be done online. And the goal is not necessarily to just replace an office visit. It's not to take a 15-minute office visit and replace it with a 15-minute video visit. It's to say, what problem are we solving? The problem should not be how do you replace the exact same things you do in an office visit. Problem you're solving is how do I take care of something that might be a routine, repeatable issue in as quick and efficient way as possible so we can scale it. And the idea is providing access to more and more people. There's certain things you do in the office you can't do easily online, although in the future, with this, I already have an app on here that can check my pulse just by video. In the next year or two, it'll check my blood pressure, my temperature, my oxygen level. You'll be able to listen to the heart and lungs with a microphone. You'll be able to do a lot virtually. So there are a lot of problems. So we go back to, I gave you a little glimpse of the future, but let's come back. In the innovation world, we always say, what problem are you solving? And in healthcare, we have a lot of problems. So the good news is there's lots of opportunity. Physician shortages, provider shortages, et cetera. In your organizations, do you find sometimes that you have way too many providers and not enough patients, or the other way around? So we do have shortages in a lot of areas, and we certainly don't have enough time in the primary care side. The required hours to just take care of routine preventive care, recommended evidence-based care, is about 22 hours a day. That's how, with the doctors that we have and the way that we do our systems, that's how much time it would take. The current hours a typical doctor works 8, 9 hours. And then I love this, I found something. This is how many hours the millennials want to work, the new doctors. They're probably a lot smarter than my generation, right? They actually want to have a life, which is good for them. But it means it's going to be even harder in our current system. So a lot of people look at this and go, oh, we just need more doctors. We need to double or triple the number of doctors. That's not going to happen. What we need instead is, and that's basically life expectancy. You can guess which one the USA is on that. What we need instead is figure out how to use doctors more efficiently. Don Berwick called the office visit, his quote was, the tyranny of the office visit. Why do we make everyone come in? And in fact, I love this quote, a big overlooked flaw with health tech, patients hate going to the doctor. That when you think about how we use health tech and do everything, the goal isn't necessarily to bring everyone in. It's, again, what the problem is how do we take care of someone efficiently, high quality, cost effectively, and that sometimes may mean not being in the office. The office isn't going away, but needs to be used more efficiently. So the good news is we're not doomed, but we have to think about things differently. The Dow went down 800 points yesterday. Scared a lot of people, but I read a good quote recently that said, things are never as bad as they seem, nor as good as they seem. And it's true now, things aren't going to fall apart overnight, but you want to look at not a one day, but a 30-day or a year, et cetera, and understand that we are in the midst of change. Now, with that said, when I started out in 1995, I was a young doctor. I joined an EMR company, and I was like, within 5 years, everyone's going to be using electronic medical records and computers for everything. It was obvious. So it turns out I was right. I just on the concept, just not on the time frame. And we'll talk a little more about how that plays out. But I wanted to challenge you with a couple of assumptions. Democratizing healthcare is a good thing. That sounds good. I'm going to suggest the opposite. Democratizing healthcare is what's killing us. Meaning that we give everybody an equal amount of time. Whether you're a 22-year-old with a sinus infection or an 82-year-old with CHF, hypertension, and dementia, you get a 15-minute visit. That is an overly democratized system. That 22-year-old doesn't want to come in and doesn't need 15 minutes. They want it to be as quick as hitting a button and getting taken care of. And that 82-year-old needs a lot more time and attention. And so we have to rethink how we stagger our system. Second, telehealth is all about virtualizing visits. I mentioned before, we're not simply saying 15-minute office visit, 15-minute video visit. We have to think about how to really automate and optimize the whole experience, just like every other industry has. And we think about travel, buying a book online. You don't go to Amazon to do a video visit with a bookseller out of Seattle. That wouldn't be efficient or make sense. There's some self-service on your part. You're willing to do that. To be able to do things at 11 o'clock at night and to find things much more quickly. So think about the same thing in healthcare. And office-based care is better than online or digital care. In some sense, yes, you can do more, but on the other hand, the NQF, National Quality Foundation, came out with a study a little over a year and a half ago. And they suggested that when you look at telehealth, online care, et cetera, the comparison is not how does it compare to an office-based visit? The comparison should be, how does it compare to what would have happened if this wasn't available? Which in most cases, in many cases, is no care at all or delayed care. And the idea is that access to care is an important quality indicator. And while you might not be able to do exactly what you could do in the office if you have Marcus Welby and everything set up, just providing some access to care is amazing for some patients. We get comments from patients who are like, I have no way to get to a doctor, a therapist, et cetera, where I live, or I have no time. What we're finding, in fact, is fascinating, and we're seeing this more and more of our visits, particularly medical, which are shorter, are being done from a patient's car. Now my first visit that I did, I still go online, I came on, the woman was driving and doing a video visit. And I had to tell her, could you please pull over? for this. A lot of people still do phone, but the idea is, why are they doing that? And why are we peaking around in the morning and end of the day? Because people don't have time anymore. And healthcare becomes a lower priority. And the only time they have is when they're leaving or coming to work and going home. Because at work they're too busy, and at home they're too busy. And they take whatever time they can. In the car is one of the last places they have where they have any free time. And they use it to call us to do a visit. It's not a good sense of where our healthcare system is, but it's a reality right now. It's one reason why we're also looking at asynchronous visits as a way to help take care of folks in a more convenient manner. So when we talk about innovation, that's a scary word because it can mean a lot of things. And boys, that's one of the hot overused words. I'd suggest that the main way we look at it is it's something new at your organization that provides some benefits. Doesn't have to be new to the world, but it needs to be new at your organization. And it can involve people, process, technology. You can have innovative people who come up with new ideas. Someone has to execute on them. There's innovative technology, digital technology, which we'll hear about a lot. And then there's innovation methodologies, human-centered design, video ethnography. There's a number of these techniques that you might want to learn and bring into your organization just to help with the thinking and ideas that you do. So now I'll give you, over the years, I keep trying to encapsulate what are some of the core principles of innovation. So I came up with the B first, and then I said, maybe I can do an ABC, and then I just kept going. And so I've got a couple for you. Here are the ABCs. A, hire A+ people. That's true in your organization no matter what. But really important to do innovation, whether it's being the strategic thinkers or the executors. B, and the B, maybe the most important one, is have a bias for action. I was sitting on a panel of innovators, and we're sitting there and like, why are we innovators? Why are we considered the guys who are on this panel talking to people? And we started talking, and what we found, the most common thing we found is we were all willing to do something. And in healthcare, that turns out to be somewhat rare entity. A bias for action, just doing something, turns out to be really innovative in healthcare because people are afraid to do something different. And all of us just have some gene that makes us stupid enough to try something new and hope that it works and learn from it if it doesn't, but we do something. C is a constant curiosity, always asking, how can we do this better? How can we do this differently? How might we reframe this problem? D is having determination. And this is when I meet with the group of innovators. We meet once or twice a year. And we all are pulling the arrows out of each other's backs because it's like a meeting where, hello, my name is Lyle, and I'm an innovator. We all feel it, that we're somewhat soul pioneers in our organization that need to be determined to try something new. E is executive support. I wouldn't get anywhere without that. Over the years, I've had some great executives, CEOs and other executives like you, who gave me cover, who let me do certain things, knowing that I was going to upset some people. I tell my kids the key to happiness is understanding you can't please all the people all the time, and that's true in innovation as well. You will upset some people with what you do. You'll make some people very happy. It's unlikely you'll make everyone very happy because by definition, when you change things, it will upset some people's lives. F is fail early, fail often, fail cheap, and always learn from your failures. But again, fail quickly. You want to make sure that it's not a year-long process that When I started at MD Live, one of the first things I did, came in, there's lots going on, it was the winter, and we were having some problems with this one functionality, and I said, you know what, turn it off. I'm a smart guy, what could go wrong? This is causing problems, turn it off. We turned it off. It was great. Most people are like, fantastic, this thing was causing a lot of problems, etc. And then I got the call from the head of sales. What the heck did you do? My guy's complaining, they love this thing, blah, 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 blah. I'm like, oh, geez. But I wasn't going to turn it back on, but I said, okay, tell me what problem it solved for them. And once I heard that, worked with the tech team. A day or two later, we came up with something that worked for them. We were able to turn it on just for that certain situation. But that bias for action allowed me to change something. Again, it worked for most, not for everybody, but then you flexed and learned. G is get dirty. This is a concept of human-centered design. Get down into the front line. You go and talk to the front line. When I've done consulting work, I worked with a CEO, and they bring me in and say, hey, we can't figure out why our doctors aren't using our radiology equipment, et cetera. No one can figure it out. I'm like, okay, let me go talk to some. And I get down and go, hey, how come you're not using this? And they're like, oh, because of this, this, and this. I go back. They're like, oh, this is amazing. I just talk to the frontline people. You guys probably do that day in, day out, but it's important to remember that. H is have fun. This is actually pretty fun stuff. To be able to disrupt healthcare and do things new. And then I brings us back to innovation. I did not go further. I've not. Maybe someday I'll get till Z, but those are my ABCs to start with. So I'd mentioned how do we innovate with IT? You all have IT systems. It actually is a great way to find, create, and then spread innovation. So you're in maintenance mode, proficiency, just teaching people the basics, starting to optimize the system. And then at the top, is where, once you've installed that EMR, you can start to optimize and innovate a little more. Unfortunately, if you want, you can get stuck in maintenance mode 100% of the time. Your teams can absolutely just be stuck in that, and they will find themselves busy. You, as executives, have to say, we have to carve out some time to do something more. So I give a story from the 1840s, 1848, specifically. 2 innovations came out in the world about the same time. Both of them profound impact on healthcare. One of them spread in 1848, within a year, became the standard across the world. There's no phone, there's no internet, a couple articles. It was so profoundly helpful. The other one, also profoundly important, still to this day is not done as religiously as we want. One of them was anesthesia. The other one was hand washing. I'll let you make the assumption as to what spread quickly, but why? One of them made life easier for the doctors. Although both made life better for patients, only one made life better for the doctors. You're not going to get acceptance and spread of innovation if it makes life harder for the people who are using it. Can you imagine, if you're a surgeon, anesthesia must have been amazing. Can you imagine before anesthesia? It was, you had to hire people to hold the person down. Surgeons were looked at as the worst of the doctors, and this changed things overnight. Hand wash, unfortunately, Dr. Semmelweis, who found that hand washing is real important, OB-GYN situation, was ridiculed because everyone knew that was not nearly that simple. And we still struggle. And this is where you guys saying, what problem are you solving? When I read about all these companies saying, oh, we're going to monitor hand washing better, we're going to figure out how to make, at some point you got to say, I'm banging my head against the wall. Maybe a better solution, is to come up with a soap that lasts 24 hours. Maybe a better solution is to hire cleanologists who can go in and clean the patient twice a day rather than try and get all the doctors to wash their hands. In fact, we did that at Northwestern, and we decreased vancomycin-resistant bacteria significantly on the floors where we actually had someone clean the patient with certain soap once a day. But again, you have to rethink what the problem is, and at some point understand you can't, if people aren't going to wash their hands, monitoring them, putting devices on them, et cetera, may not be the best solution. I often say there's no quality without use, but there's no use without usability. And so that's when you think about whatever you introduce into your organization, think about how does this make life easier for my providers as well as patients. So in the book I mentioned, we divide the book into 3 categories. How do you innovate around EMRs? How do you innovate around telehealth, or telehealth being the innovation, and then advanced technologies? So I wanted to share a couple of lessons that we learned. First, I call it share the care. that means find the MVI, the minimum viable innovation. In the startup world, we call it the minimum viable product, but I call it the minimum viable innovation, and operationalize it at your site or organization. And it's okay to borrow ideas from others and spread it. In fact, what was interesting is in this section, we talked about 3 places: MedStar, Setma, Southeast Texas, and Reliant Medical Group. And they all essentially did the same thing. They sort of brought into their EMR reminders about care gaps in some way or another. But they all did it a little differently. They all had different EMRs, they had different process and styles. But the minimum viable innovation was each of them saying, we want to make it easier to do the right thing. We want, when our doctors go into the system, to quickly be able to be reminded what this patient is due for. And therefore, with one click, be able to execute on it. They did it differently, but the concept was the same. And when you read the book and you read those 3, you're almost invariably going to say, oh, I get how I could do this at my organization. I don't have to do it exactly the same way, but it's close enough. Second, it's always more than just technology. People and process are often much more important. Technology, though, can, again, help you accelerate and scale. At Northwestern, we implemented a program I called the Inflection Navigator System, in which case we basically identified patients who were going through an inflection point. They just got diagnosed with cancer, right? Or some other serious disease. And we said, what should happen over the next 2 weeks? Because quite honestly, in many cases, it is not a great show, right? It is a horrible process of a couple of weeks before you get in the system. I said, let's just look at that inflection point in healthcare. When something all of a sudden happens, in the mental health arena, maybe it's a new diagnosis of schizophrenia or bipolar, but something needs to happen, and let's see if we can create an orderly way to make sure the right thing happens and make it easy for the doctor and patient to get through this system. But a lot of this was, once we identified it, assigning people to help with that. The Children's National Pediatric Organization had an automatic adverse event detector. Every morning, a nurse would get a list of adverse events that happened in the past 24 hours. Too much heparin given, a patient needing Narcan because they were overdosed, and then they would go and individually study each one and come up with ways to improve the system. So the technology identified the problem, but it was a nurse who went and figured out how to improve upon it. And California had a big teletranslator system. They had a big problem. California has so many languages, and they don't have enough people at every hospital. So a bunch of hospitals came together and formed a consortium where whoever you had in your hospital, you sort of loaned out to other hospitals, and they just use a video link. And again, the video link was the easy part. They used like Skype or something. And the hard part was just organizing all those people to get them together. So it doesn't have to be fancy on the technology side. It just needs to solve the problem. Third, it's smart to start small. I mentioned competitions, crowdsourcing, grants. This is one where I did, we're at Northwestern, we just gave iPads to patients with cancer. This is about 5-6 years ago, just to distract them, keep them integrated. I mean, the love that they had for this was amazing, because a lot of these folks, they didn't have, particularly if they're lower socioeconomic, they had nothing to do in the hospital. And this gave them something to do and provided a much better patient experience. One of the stories in the books are about Memorial Hospital was given a home blood pressure cuff by Intel, and they said, how can we use this, but not just for hypertension or CHF? And the OB-GYN said, hey, we would love it to monitor moms. And they actually were able very quickly with like 4 units to test out and find that they could identify a variety of problems in mothers well before they came in and did their visits, and they spread that system afterwards. Having Connect, Google Glass, these are just ways to start saying, how might I use this in my organization? May not be something for today, but helps you learn about tomorrow. I said, beware of pilotitis. You don't want to do too many of these and just do pilots that never go anywhere. Learn quickly and figure out if it makes sense or not. But try something new. Whenever anything new comes out, whether it's an app or device, like I was the guy at North, I would always download it and try it and say, how might this apply in healthcare? I also suggest don't miss the low-hanging fruit. This is a Dilbert. If you can't see it, that's a piece of low-hanging fruit, and the boss is walking right into that, pokes his eye out. I give a story we did a little competition at Northwestern where we said, give us your ideas. I have some funding. I had some money through my program. Give us your best ideas. And people would send in ideas, and one of the ideas was, we need more telephone chargers in the emergency room. Because people come in, they want to be on their phone, it runs out, so we have to get a way to charge. And we give out these phone chargers, and they disappear in the emergency room. So we need more. I said, okay, but if I just give you more money for more charge, they're going to go away anyway. So I found this device. I was at a conference, and it was like this 80-pound device that had, you can see like 5 to 6 different chargers for all different phones, and I just plunked it, 2 of them down in the emergency room. People loved it. I mean, like, people were fighting over it. There was literally a fist fight at one point. Another time, someone grabbed one of these devices that was on a stand, 80 pounds, brought it up to another floor because he couldn't bear to not have his phone charged. We hit on something that struck a nerve. That was it was relatively cheap, a couple $100 for each of these things. But it improved the patient experience immensely. Can you imagine being in the ER, not being able to communicate, your phone's right out because you didn't realize you're going to be in the ER? Little things like that. And I tell that story to other innovators who say, hey, what can I do innovative? I say this, and they're like, oh, that's not innovative. I'm like, well, do you do it at your organization? No. I'm like, then maybe it is. Does it improve the experience? Does it make life easier for people? There's nothing wrong with some small wins. And in fact, after I did this, it just gets you credibility that you're doing something that's actually useful. And that started spreading, and our other ERs and urgent care started doing it. And the idea is you want to have a couple of small wins, because if you want to get some big wins, you want to get some credibility and experience along the way. Fourth, mash up wild ideas that might be used in other industries. So this is one company I'm with, OneView. The founder is a guy from Ireland. Great accent, fun to listen, great storyteller. And he explains how he was in the hospital for a knee surgery, and in Dublin they had a room where there were 4 people and 1 TV, and whoever was the biggest guy got the remote. And so Mark didn't get to watch what he wanted to watch. And he was a salesman, and CEO of a business, but was a salesman at heart. And he was flying to a client a couple of weeks later. And on the plane, he had his own individual TV and ability to choose things. He goes, how come I can't have that in the hospital? And he wound up starting a company to do just that, to create this individual little platform that could pull in entertainment, ordering your food, calling the nurse, education, etc. UPMC did something similar in Smart Room, and that's detailed in the book. And that story was another great story. It was based on a problem. A woman came in with an infection, and she needed IV antibiotics. She was otherwise healthy, did have an allergy to latex. It was well documented in her EMR. But when the nursing team couldn't get an IV in, they called in the IV team. These are for, you know what a diva is? We called it difficult IV access. So she was a diva. And they called in the IV team, who were amazing at this. IV team got in, they got the IV in great. But the IV team didn't realize that she was allergic to latex. And they used latex gloves. And she had a severe reaction, and she sued UPMC. So they sat around and had a little innovation brainstorm and said, just come up with whatever ideas you can. There are no limits. How could this have been prevented? And they said, well, what if the room was alive? And when you came in, it recognized who you were, your role, and it flashed to you on a big screen or told you what you needed to know for your role. And from that, they evolved this concept of, well, it could be a monitor, doesn't need to be a whole room. They can use RFID, and they created the smart room concept. And they wound up creating that, rolling it out, selling it to Cerner, I believe. And again, out of crazy ideas sometimes, some interesting things can come up. The Kaiser's online panel. Many organizations in the technology industry use online panels, meaning you can, if you're Best Buy, you might have a big panel of people who will answer questions online. Kaiser did the same thing with about 20,000 patients. You probably do focus groups, but online focus groups are a lot easier and quicker to get quick answers to things in a significantly cheaper way. And so it's something I'm surprised healthcare organizations don't do as much of as I think they can or should. This last story is about gaming. Gaming, of course, is used in so many, is so popular. How do we use it in healthcare? This is Snow World. Snow World's a virtual reality game where you basically are in a snowy world and you're throwing snowballs at snowmen. And it's not the most exciting game in the world, but it was created for burn victims while they were getting debrided, because it triggered in their mind a sense of cold, and it significantly decreased the pain that they experienced. Remission and Dr. Hero were created by Hope Lab, a nonprofit organization funded by the founders of eBay to create ways to improve the experience for children with cancer in this case. Both of those were video games that were pretty fun, but part of the game was teaching kids what cancer was, the importance of taking their medicine, etc. Fifth, apply new innovation tools to old problems. I mentioned earlier video ethnography is something used in the innovation world. Companies like IDEO, Gravity Tank, etc. What they'll do is they'll actually videotape and interview someone and multiple people, and then take that back and learn what is going on to be able to come up with new ideas, new products, etc. And we did that for a diabetic population at Northwestern with Gravity Tank. I couldn't understand, diabetes is a treatable disease, how I had patients who had a hemoglobin A1C over 9, really poorly controlled diabetes. And so we identified about 8 of them. You don't need a lot throughout my practice, not just my practice, my whole group practice, and went out and actually did interviews with them in their homes, videotaping them to find out what was going on. I went on one of these, and I went as a photographer, not as a doctor, not as an interviewer, just to be part of the team. And this gentleman, looked pretty healthy, but I knew that he had a pretty poorly controlled diabetes. And it turned out, he felt fine. Diabetes is often a silent disease. And when the interviewer asked him, do you understand what diabetes is? Right, because we assume these people don't understand. He knew exactly what diabetes was. He knew what the complications were. He didn't care about that because as far as he was concerned, he really didn't have diabetes. His doctor thought he had, but she's a wonderful doctor, but she over-worries about me. And my glucose is high when I go there. That's just because I ate beforehand. And she called me up one time, and she told me my glucose was so high I had to go to the emergency room. I laughed. I felt fine. I appreciated how much she cares about me. So what we found was, story over story again, was we always wrongly assumed patients just need more education about diabetes. They didn't need education about diabetes. They needed understanding that they had diabetes. And we had to simplify it for them. And so, we came up with a concept of know your numbers, and just said, as a diabetic, you just need to know one number, your A1C, and know what is a reasonable range for you. And we started seeing patients who were accepting that they actually had diabetes, and even though they didn't feel it, it was important to treat. But what was really powerful was when we all got into a room together and they spliced together, right? We had 20 plus hours of video. They spliced everything together to show certain concepts. People understand they have diabetes, and they showed video of people explaining these patients who we didn't think understood, explaining diabetes, explaining the complications, saying they didn't think they had diabetes. And it hit us. We were in a room of doctors, diabetic specialists, et cetera. And all of a sudden, it hit everybody that we have to change our thinking. We can't put up signs that say, diabetes will cause you to go blind. They didn't care because they didn't think they had diabetes. So it's a really powerful instrument. Number 6, get inspired by others. And this is outside of healthcare. This is one of the most fun things I've done with this group, the ILN, is we call it innovation safaris. And this is, imagine if your healthcare system, what can we learn from Nordstrom's? I took our executives at Northwestern on a trip to Nordstrom's. Nordstrom's has worked with us in the past. And who here has gone to Nordstrom's? I guess, by the way, it's a lot more females than males, and they all know, right? I mean, is the service there great? Like, amazing. Is your healthcare organization service to that level? What if it was? And so we actually talked to their client, their customer experience people, how they hire people, how they empower people, right? They don't just give them a bunch of rules, they really empower people, how they track people, et cetera, and what their philosophy is around the customer experience. It's so important. And to have our executives on our healthcare team, EVPs, and going and listening to this and just going, wow, we thought we were good at patient experience, like we have so much to learn. How about a NASCAR facility? Went to a NASCAR facility, and what can we learn from them? So it turns out they showed us really interesting things, including how you have to put your initials on every piece of equipment in that car. Because if something bad happens, you're accountable. And your initial is on that. That is a level of accountability that we certainly don't have in our ORs to that degree. And it inspires you and gets you thinking. There's a great book, What If Disney Ran Your Healthcare System? It's out of press, but if you can buy it, you can get it used. It's amazing. We can learn so much from other industries. We did a little fun project around Tom's, Give One. We did this like 10 years ago or so, and we said, maybe we can take something from this. What is something people don't want to do, but maybe they do if they felt it could be done with others? And we said, well, what if there was a, get one, give one colonoscopy, right? Because people don't want to do colonoscopies, but like, what if you said, look, if you get your colonoscopy, we'll get it for someone else too who really needs it. It gives now you feel. Actually, Walgreens did that with flu shots, right? You ever see that? Get a flu shot, and we will give a flu shot to someone who can't afford it. And it gives you, and we learn, right? Tom's did a great job of that with shoes. You feel a little better about buying shoes from Tom's. You feel a little better about getting your flu shot, maybe your colonoscopy. Okay, so now how do we transform care? What will shape our future? There's a lot out there. Again, this is where it can get overwhelming. Value-based care, telehealth, digital tools, everything on mobile, big data, et cetera. So I know it's hard to see, I apologize here. This is like 100 years ago, this is what some French illustrator thought the world might look like. And he has like little robots doing, being a maid, the barber. I actually like this one. It's hard to see. These are students, and they're like these electronic caps on them as they're learning things. That actually might be the closest to what we have with the internet. This was like, again, 100 years ago. This is another one that's more recent. It says, in case of emergency, break glass. And you got a little doctor behind there and all these computers doing all the work. But that's what we're talking about, right? You don't need doctors to do the basic stuff. We need to use doctors, providers in healthcare of every sort to do what they can do best. I often call it the 3 E's. They can empathize better than a computer, at least for now. They can educate in ways that are really personal and really explain why this particular medicine or this therapy is important and helpful for you. And they have an expertise that is, I call it the spidey sense, whether it's medical or BH, et cetera, that they're able to use. But the doctors are not the best at remembering every care gap and mammogram and documented everything. And how do we use technology to do that? This is another way to look at it. I call it stuff that needs to be done, how much time doctors have to do that stuff. That's our world today. This is what bothers me. But I often say we don't have a shortage of physicians or providers. We have a shortage of using them efficiently. If we use technology right and team-based care, we actually will have more enough time. We have enough providers of care if we use the resources available to us. Again, similar to every other industry. So one of the things I've done, I have a whole different talk on this. How do you 10x primary care or mental health care? How do you go from a panel size of 2,500 to 25,000? It's some combination of improving the workflow efficiency in your EMR utilization, using virtual care for routine stuff, and taking care of complex patients in a more thoughtful way. To summarize this in a way that you'll be able to take it home and remember it, I'll often say we need to get sad and fat. Now that might not be something that you think of in healthcare as a way to solve our system, but I have a different, I'm a doc, we love acronyms, health providers, and we all do, right? So what's SAD mean? How do you simplify, automate, and delegate routine, repeatable care? Simplify, automate, and delegate. And then how do we use financial incentives, analytics and AI, teamwork, telehealth, and technology, to bring it home? SAD and fat. I honestly tried to think of a happier, better acronym. This just came to me. I might be wired that way. I don't know. But if you can get SAD and fat, those are some of the tools that you have to start thinking about how we can do better. So what does disruption look like? Amara's law is often attributed to Bill Gates or some other smart folks, but he actually was a scientist. He said, we tend to overestimate the effect of a technology in the short run and underestimate the effect in the long run. Let me give you a pretty easy example. The iPhone came out 10 plus years ago. At the time, we're like, oh, this is going to change everything. It didn't change it overnight, but it sure did within 10 years. And so this is how humans think about the future, very linear. This is how technology actually changes productivity. Not as much at the beginning, but then can get pretty darn big and eventually get there. So when you read about something new, again, don't overreact, but think about eventually it's going to mean. So all those things you read about right now, and go, oh, that's, may or may not affect us. I could see how it could be fun, but eventually, again, we know this is going to become more important in healthcare. Again, a little hard to read here, I apologize, but this is a slide that talks about sort of the new emerging trends or technologies. Innovators, early adopters started, incumbents begin to adapt, mainstream customers adapt, and then there's a tipping point where either the new normal, you jump on it, or you lose out. This is Blockbuster, and Netflix. This is Sears and Amazon. Walmart, did not go this way, right? Why is Walmart different than Sears? Because Walmart embraced new technology. They went online. They took advantage of what they can do in the stores better. They also went online, and they became a big online retailer. They still haven't fared as well as Amazon, but they've not done as poorly as Sears. So let's go back to that Blockbuster analogy. Blockbuster was doing well. Around 2000, I was actually at this hotel in about a year ago, speaking at a conference, and they had much better keynotes. That's amazing. The guy who founded Netflix, right? Amazing guy. It's a huge auditorium, and he talked about how when he went to, and his team went to Blockbuster around 2000, they were struggling at that point. They were still early on, and they said to Blockbuster, could you just buy us for $50 million? We just want to pay our investors back and give our folks a job. Blockbuster laughed them out of the room. We don't need you. We can figure this out. People love our stores. People want to come into our stores. They love the feel of the videotape. They love talking to the people in the stores. They walked out of that room saying, "We are going to beat those guys." That was not a good feeling, and obviously they did pretty well. So a couple lessons. Never forget what you're really selling, right? You're not selling a videotape, you're selling an experience. You're selling, in this case, the ability to watch something online. Again, you're not selling an office visit. You're selling how to improve mental health in whichever way that happens. You need to be willing to adapt, and half measures won't cut it. Being able to say that you do a couple telehealth visits, or have one app that you work with is not going to be enough. The customer-driven approach always wins. Your customers, our clients, our patients, they are looking for more convenient, cheaper, but high-quality care. And they will keep looking until they find it. They will keep looking until they can do everything healthcare that they can do in every other aspect of their life. So who will disrupt you? Well, they're going to be highly convenient, cheap. Google speed with Amazon prices, right? You guys have heard of Better Talk, and some of these companies that just have online chatting, etc., and do it very cheaply. They're going to be backed by automation, and they're going to be available 24/7. It's an example, a local place in Chicago, Smart Choice MRI. They just popped up all of a sudden. There are these MRI facilities that you can go to, and they have cash prices. They're much cheaper than the hospital facility. They have no radiologists on site. They work with Cleveland Clinic to do their readings. So if you're a patient and you can get half price MRI, actually much more than half price, like a fifth of the price, like $500 versus $2,500. And it can get read by someone from Cleveland Clinic, and it's a couple blocks from you, and there's free parking, or you can go to the hospital system. That's the type of things that people are looking for. The other important thing is, besides convenient, cheap, they want to have this lifetime relationships. That's what Google and Facebook, et cetera, really, and then they learn more about you. And healthcare, that's hard. That's where you guys can benefit more, because and have relationships with these patients, but sooner or later, people are going to want to do more and more of it online. So what will disrupt you? I know you heard yesterday a little about there's artificial intelligence, of course, that is making it easier to do things. Think about routine things that can be done as well as more complicated things. The Internet of Things, this idea that everything can be monitored in the future. As you probably know about, I think it's University of Wisconsin or the CHESS group that does monitoring for people with substance abuse, where they know when they're going to physical locations based on proximity of when people are going to physical locations that trigger their abuse. And they will text them and connect them to a counselor if they can sense that they're going that way. You could theoretically look at their email, their social media posts, etc. The tricorder, this is this concept of, we're getting to the point of between genomics, imaging labs, et cetera, really detect and diagnose things quicker and easier. Biohacking, this is where, whether it's CRISPR for gene editing, nanotechnology that you're ingesting, these are things that are going to disrupt healthcare in general. And you have to think and sit and say, what if computers could manage 80% of mental health care? What does my organization look like? What if we cured substance abuse or schizophrenia with a CRISPR genetic change? What if most people live to 120? So these are challenges you might take. Again, not that these things are happening overnight, but sometimes extreme ideas are a way to innovate. Years ago, the Innovation Learning Network, we had a little brainstorming session where we said, what would healthcare look like? How would I take care of people in the following extreme scenario? Hospitals and clinics were banned. What would that look like? And it made us think differently, not just what the future looks like, but really made us stretch our minds. We actually came up with ideas of Uber-like ambulances that would be floating around and go, whenever you had a problem, they would show up at your door. You could do surgery at your house that way, get MRIs, labs, et cetera. It really made us think differently. This was, by the way, before Uber even started. It's like 10 years ago when we did that. But again, think about extremes, because those extremes you might learn something. And come up with new ideas that you wouldn't be able to come up with otherwise. So in mental health, who and how do you get disrupted? No more time on the couch, the rise of digital mental health therapeutics. This is funding. I think, again, you heard some about this yesterday, but there's a lot of money going into this in a lot of different ways. And most of them will not win, but some might. As you know, there are 10,000 apps on the app stores. They fall into a couple of categories. There's online therapists and psychiatrists. There's online chat therapy. There's digital therapeutics that may or may not involve a coach. It may be completely just self-service online. And then there's these new technologies. Limbix does it. It's a VR-based treatment. Another company that involves smart journaling and voice biomarkers. And IASO, a company that uses AI, and I'll talk about them to support therapy. By the way, quick call out, session later today, we'll be evaluating these apps. And so give a call out to that. I'll be talking a little more about going in depth. How do you evaluate which apps are the right ones to consider? So IASO is an interesting company. Have any of you heard of it? IASO? One? Yeah. What they actually have the software that allows you to chat with a patient, typing, right, for a 45-minute visit. But it follows what you're typing and actually makes suggestions based on the patient's history, therapy, what you're typing, using artificial intelligence. Perhaps you should use this language. You should ask this question, etc., to make sure the therapist isn't missing anything. They're actually expanding into voice so that if you do a phone call or talking to the patient, it can also use natural language processing and provide the same thing. But pretty cool. Again, make it easier to do the right thing. And eventually, at what point does it just take over therapy completely? So as you're working with startups, I would suggest asking 3 questions. 1, understand who uses it. Is it the doctor, the patient, an administrator? Who benefits from it? Does it save the patient money? Does it improve quality, etc.? And who pays for it? And then how are those aligned? It's another Dilbert. I found a way to save $1 million by spending only $10,000, Dilbert says. The $10,000 would come out of my budget, but the savings would go into someone else's budget. Not feasible. Our stockholders might disagree. Well, that's why they aren't invited to the meetings. We see this a lot, right? You have to align incentives. Does it make sense for you to invest in something that saves your payer money? It's tough. It might be the right thing to do, but how do we align incentives? And these new startups, a lot of times, they'll come and say, hey, health system, pay for this, and it's going to make life easier, save money for the patient, the payer, et cetera. You're like, why am I paying for it if I get no benefits from it? And so you have to work with these folks to align their business model correctly. Lastly, Dale had challenged me to say, what might the future look like for mental health centers? And what do you guys do well? What you do well is you have an expertise in treating some of the most complex chronic disease out there. You know case management and care coordination. You understand team-based care, social determinants. You're dealing, again, with some of the toughest issues, mental health, substance abuse. You understand how to track, how to coach, change behavior in this tough population. And I wondered, how might you transfer that expertise to other chronic illnesses? And in fact, how do you maybe own some of this top? Will the mental health centers of today become the complexology clinics of tomorrow, not just for mental health, but for other diseases? I challenge you to think about that, and that's one of those things which, again, would never happen overnight, but is that one of your arcs? Do you expand and take your expertise in this very tough area, which most primary care clinics are not set up well to do, and transform yourselves in, at the very least, supporting those folks in the primary care clinics with their really tough patients? It might be a whole new line of business where you think about, if computers are doing more and more of the routine work. Is your goal to make sure the right people have that routine work, and for your infrastructure, your people, your process, your technology to really help in those patients who are not routine and who need a lot more attention in a variety of ways. So it's an interesting thought. I'm going to end on that. Actually, I'm sorry. I've got a couple more principles for you. Just to summarize, as I said, takeaways. What you can do at your organizations. One, spend a lot of time framing the problem. This is the old quote from Abe Lincoln, et cetera. If I have to cut down a tree in an hour, I'm going to spend 15 minutes sharpening the axe. Same concept. Understand what problem you're solving. Little bets, big wins. Try a lot of small things, get some experience, get some credibility. Create a balanced portfolio. You might have small projects, but along with bigger projects. Leverage IT. It's the best way to scale and spread a lot of your innovations. And you're going to need to be the leaders to charge. This is a little cartoon that says, who wants change? Everybody raises their hand. Who wants to change? It's hard. That's why you're leaders. That's what you do. And you've got to make sure you inspire why people want to do it, but make it easy to do the right thing. So more specifically, how do you empower innovators? You may or may not be the innovator. You probably know someone in your organization who wants to innovate. They're probably the guy who you have to talk, or a woman who you have to talk to on a semi-regular basis because they're disrupting other people. But how do you channel their energy in ways? And then, what type of team do you build? You can't just have innovators. You need project managers. If you want to get really sophisticated, you hire actually folks called designers, human-centered design trained folks. You think about doing other things that inspire innovation. You may have leaders. Do you have a chief innovation officer or chief digital officer? These are new roles that are becoming more common in organizations to help oversee and lead this. Have a safe space. You might pick one of your offices, one or two of your clinics where you can try new things, and give them the ability and incentives to try and do something new in a safe way. And then again, think about how you disrupt yourself before someone else does. Stay ahead of that game. Don't be the Blockbuster of the future.